and what's happening in the next few days real quick so we can start exactly in time. We don't want to waste a minute because we have amazing content. I have to be honest. I saw what Thomas and Lori have, and it's amazing. There are so many tips, so many different concepts that you can improve your surgery big time. So I'm going to start very quick. We're talking a little bit about Abdominal University, that is this community, this ecosystem, this platform to share. Okay, this is our mantra: is to share knowledge, to create community, to know each other, to have a good time, and why not to communicate differently in medicine, and to have this, to let technology give us this bridge between us, and share knowledge. We know we are all better the moment we share knowledge. Let me see that I don't see. Just give me 1 second. There you go. Then what's happening on Monday? On Monday, it's going to be very, very interesting. Thanks to Dr. Takashi Ida from Brazil, he made this organization, to Ike Ahmed again, Shin Shamane from Japan, Ron Gyo from Singapore, and here I'm going to be only a spectator, right? I'm going to talk about what a master is, and these guys are going to present each a case and talk about what makes them a master in cataract surgery. You can't miss it.
It's the prelim for that.
Because of timing, this is going to be a little late. For Abdominal University in Mexico, you have all the times there. We will wait for you there. And probably Lori and Tom.
I sent a text back to her saying,
Lori and Tom, I don't know if this is in Spanish, but this is something, we're going a step further. And tomorrow, this is going to be very interesting. We're going to have one of the coaches who won more things in football, in soccer, right? With another soccer player who was a world champion in 1986, and another goalie that was amazing. So we're going to talk about the analogy between soccer and surgery and ophthalmology, right? Discipline, resilience, passion, teamwork. And this is going to be, we are so excited about this. These guys are actually famous, and with us, and they gave us their time for free to talk. So I think this time is bringing amazing things, not only about doctors, but connecting each other, right? We ask everybody, let's see how we are more than 60. We ask everybody always to follow us in social media, but also to create community, not for any other reason, right? If you follow us, you can see what's going on, what's happening. It's in Spanish. We're trying to make the platform multilingual, and that's going to be a challenge, but I think it's going to be great. We asked the guys from YouTube to subscribe so the channel keeps growing. It's very important for us. And we are 5 minutes away, so I'm going to start with the intro, okay? And we prepared this a lot with Tom and Lori. We took our time to prepare this, to give you guys the best we can, specifically to try to transfer skills and knowledge. That's not easy. It's not easy sometimes to transfer experience. But right now, with technology, with videos, and with good tips, I think you will be changed from today. You're going to have many tips that are going to be very good for your cataract surgery. But most of all, there are tools that you can, you can do like tomorrow. The moment you are practicing and trying to keep the skills or improve it during this pandemic, you're going to probably be able to make it. Just very quick, Ophthalmic University has now 2 different activities. In the morning, we have workshops. They're more like individualized, and they're about specific topics. Put you an example. Next Monday, we're going to have glaucoma guys for 100 people talking about new techniques for surgery. The virtual classes are different. They're like this. There is a panel, and we do a presentation. So they're completely different activities. We ask you again, where are you guys from? We're almost 100 people, and we still have 5 minutes. So please tell us in the chat, where are you guys from? People also from Colombia, Panama, Ohio. That's you, Lori, right? That's your crew. Oh, Cincinnati, sorry.
Yeah, I don't, where in Ohio?
Oh, let's ask.
Chris?
It
Yeah.
was Chris Meaning. Then Monterrey, Mexico, Guatemala, Dominican Republic, Sanibel. Sanibel? Is it close by?
I don't know.
Let's Google that. Then we
Yeah.
have Ali from Spain. Oh, hi to everybody in Spain. We know it's late there. Imagine a Friday night watching Cataract. You're like us, I think. You need to love Cataract. Oh, Poland. Nice. Alexandra. Nice to meet you, Alexandra. Hope we can keep in touch. We love to have people from, from places that are very, very far away, and probably it's not a good time for you, right? In Poland, maybe it's very late. Venezuela, great. Let's put the title here and chat a little more. We have 3 minutes, so we can be in time. I'm just gonna say that we have a surprise in the middle. Okay, we have a surprise. I don't think that anybody did this before. We in Abdominal University, what we want is to give you, to change even the methodology in what we teach, right? Let's use technology, but to give you tips, to give you tools, not just to give you, lecture, 1 hour lecture, and then it finishes and it's like, okay, how did I change? Which tools do I have? But then again, I'm going to take 1 minute to go back a little bit. And people who didn't see it, we are more than 100 people. Tomorrow, this is limited spots, soccer and surgery with Carlos Bianchi. It's if you guys don't know it, from Boca Juniors, Argentina. He was world champion, won so many titles, beat Real Madrid in the final of the World Cup. He's gonna be with us. We are so excited. We just can't believe it, And also talking about these concepts that I think they really relate to surgery, to doctors, to surgeons, to people in training. I think it's going to be great. We ask you to take the picture and follow us in social media, to subscribe in YouTube. And I wanted to tell you this one on Monday also, very limited places. Mastering Cataract Surgery, Ike, Yamane, Ron Yeo from Singapore, and Takashi Ida from Brazil. It's going to be great. I think it's going to be very, very interesting. Okay, so we have 2 minutes, and I would love for Tom and Lori to start, building momentum and tell the audience what is this about. You can go, guys.
There. Oh yeah, there. I'll get started. My name is Tom Oding. I appreciate the opportunity to be here, Ibo. It's very exciting for me to participate, and I'm honored that you would ask me. I have been at the University of Iowa now for almost 30 years, and have been doing a lot of teaching in cataract surgery for the last 25 years or so. And what we're hoping to do is just share some things that we've learned. And maybe make it a little bit easier for people to learn. And then at the end, I had a couple of things I wanted to share with those of you that are teaching, if anybody's still here at the end. So we'll see if we get to that. I'm excited that Ibo invited also Lori Provencher. Lori was one of our residents at Iowa a few years ago. And then she went on to be a fellow at Michigan in glaucoma. She's an amazing teacher, an amazing surgeon. She did some work with Orbis. Some of you may have followed that. She's, I think she would give a nice perspective for someone who's not so far out as I am, and maybe understands a little bit more about what it's like to have recently learned something. And so I hope that will be useful. So this is, we're doing this to try to help you guys. So if there's any questions you have or anything, we'd like to make it as best we can for you. I apologize. I see there's a lot of people whose primary language is Spanish. I apologize. I just know one language, and that's barely English. And but hopefully we can help you with that, and Ibo can help us with that.
That if you have any questions, I can translate very fast. But we're on perfect timing. So should we start?
Yeah, great.
Great. Sorry.
Okay, so these are our objectives for today. What we're going to do is travel stepwise through phaco in a natural way. And we're going to discuss our top 10 pearls with you as we go. Again, we're going to try and bend your learning curve the best we can. There's probably a variety of skills out there and skill levels. So we're going to try and hopefully give something useful for everyone. But try and keep an open mind, even if some of these things seem obvious. Try and imagine how you could implement our advice in a new way. And then lastly, like Dr. Oding mentioned, we're going to try and increase your appreciation for the paracentesis, which seems to be the easiest, smallest step of cataract surgery. But if you can find nuances within that step, I'm sure you can find nuances with anything. So we'll end up with that, and also hope to share a few tips on teaching and using the paracentesis as the attending surgeon.
Yeah, we left the best thing for last. So you need to stay for the last second, because what we're going to tell about the paracentesis, I think you never heard it before, and it's an amazing tool for us. So we're going to ask Lisandro, and we're going to ask you guys to tell us about, we really want to know about you guys. We want to tell about your experience in cataract surgery. So please answer the poll, answer the questions. So they're going to give us a little understanding of your level, and then we can discuss about that. There's a lot of people signing in together. Hi, everybody. There's a quick question, and also we would love to know where you guys are from. Okay, we're gonna give it for 3 more seconds, and then we can see the results. But okay, let's close it. There you go. So we have, we have everything, guys. Okay, so we have people with a lot of surgery, even 50% from more than 1,000 surgeries. And it's going to be interesting. It's going to be challenging, I think, for us, but it's going to be interesting. So we have people with different experiences. Okay, so second question, it's going to be fast. There's going to be only 3, don't worry, guys. But it's very important for us to understand also what step do you find most challenging? And it has a why. So that's why we're asking this in the beginning, okay? We're gonna give it for 10 more seconds, and Lori, you can continue. Interesting.
Mm-hmm. Great. So we'll try and tailor what we say to this, but I think there's some good stuff in here in our presentation for everybody.
Yeah, I agree, and very interesting. Yeah? Very interesting.
Yeah, a lot of the studies show that the few studies, there's not that many. There's like 3 studies that ask this question, and usually the more junior you are, the more you want to know about capsulorhexis, and the more senior you are, the more you want to know about nuclear fractus. So it kind of makes sense the way our audience is distributed.
All right, so I'm going to start off with tip number 1 without further ado. This is a photo of me in the operating room as an assistant not paying attention. I'm staring at my attending's hairnet instead of actually doing what I'm supposed to be doing. So tip 1, your surgical success starts way before the first incision. And what I really mean by this is that learning starts before you ever actually perform surgery. And this is true whether you're learning phaco as a really junior phaco surgeon, or whether you're an attending and you're trying to implement a new skill. And I think it becomes actually more important when you're an attending on your own and you don't have a mentor there by your side. So Ivo, you can go to the next slide. So most of us begin as assistants, and I think it's really important to be an active learner while you're an assistant. Try not to just be there to wet the cornea. Think about how the attending is doing what they're doing. And it's really useful to stop and occasionally look around the scope at the attending's hand position. Only about 50% of what is actually occurring when it comes to surgeon skill is really visible under the scope, I think. The rest is really how the wrists are positioned, maybe how they're sitting, and ergonomics. So make sure you're looking around the scope occasionally. And then also make sure you're asking why. One of the most insightful things I've ever heard anyone say is that they had a fellow one time tell them, "I wish I really could hear what you were thinking." And so a lot of times we don't really know what's going through our attendings' minds. Maybe it's nothing. Maybe they've done 10,000 cataract surgeries and they're totally bored. But for the most part, it's helpful to know kind of if they're pausing, ask quietly, what's going through your mind right now? Like, are you worried about the capsule? Are you worried about the zonules, that sort of thing? And then also, I like to kind of anticipate the next step. So if I'm operating, what would I be doing next? What instrument would I be calling for? Those sorts of things, because that'll really increase your efficiency and your confidence when you finally take the seat. The other part of this is really picking the best patient for these early cases. So again, if you're starting out phaco, or if you're trying to pick a new patient to try a new technique on for glaucoma surgery or something like that, finding the right patient is so important. Also thinking about anesthesia, what kind of anesthesia you're going to need to maximize your success. Positioning and exposure, are they going to have a challenging orbit? How's their dilation? Are they going to have other issues with the zonules or the capsule that maybe they're not the best person for these early cases? And then also just getting a thorough history and a history of prior surgeries. So again, it's all about anticipating when and where something might go wrong. And the ideal balance, though it's not always possible, but the ideal balance is to have the case less complex than your current skill level. And this is really what we owe to our patients as we learn to maximize patient safety. So step number 2, actually, I want to go to Tom, Ivo, if you want to add anything to that. I know you all have a lot more teaching experience than I do.
Let's go one slide back if we could, Ivo. I really think when you're really junior in your learning curve, that you should try as much as you can to get involved in the OR. And so sometimes the way that you're best involved is maybe acting as the technician, or at the very least, you're anticipating what's going on, as Lori said. So what we'll do with our very junior residents is we'll have them act as the technician. So they'll fold the lens, they will anticipate what the next instrument is. And so that process of being engaged in the OR when you're very junior is very different than just sitting there and watching like a medical student, because this is your job, this is your career. So you should be thinking about everything. Why is there more than one viscoelastic? Why is he asking for this now, or she asking for this now? And then if you actually are the technician, if you actually scrub it and act as the technician, you can really get a lot out of those very early cases. So I think that's the sort of the most early. And then the other thing that Lori was mentioning is really paying attention to the patient. I mean, if you're junior in your cataract skills, you're often better at whole body skills. You've recently been an intern or medical student or something. And so really be the expert on that patient. Figure out what's going on with them. Are there any issues with them? Or are there any reasons why they can't hold still? Is there any reasons why there may be some issues with them not tolerating the surgery? Is there funny things about their head that make positioning difficult, which Lori's going to talk about later? But really, you own the rest of that patient if you're very junior. And that's also it's a different way of looking at this process, as opposed to just sitting there and observing. You really are trying to own this process a little bit. So I totally agree with you with what you're talking about, Lori.
I agree 100%. And I would like to go back to the active learning experience, right, Lori? because, you know, people know that I'm obsessed with this matter. I'm doing a master degree because I'm so obsessed about how an adult learns, and all theories come to the same conclusion, that it's, you learn when you're engaged. So if young people can understand that and be engaged in everything that is happening, not only with the surgeon, but in the environment, right? Looking at the nurses, looking at everybody moving, what's happening, what's going on. I think it's amazing. It's an amazing tip.
And one more thing, and Lori, and that is that the interesting thing about cataract surgery is the part of the case that's safest is the back part of the case. So when you're learning, try to get some opportunities at the end of the case. So in other words, if everything's gone really, really well with the standard cataract surgery, the very end of the case where you're just removing the viscoelastic, or you're placing the lens, or you're getting a little bit of cortical material, those are much safer steps for a junior person. And yet those are very important times for you to learn sort of the depth of the anterior chamber, for you to learn some of the important things, like you move your hand up, the instrument goes down, you move your hand left, the instrument goes right, those sort of things. That can be learned best at the end of the case when everything's safer. So the very first thing that I would recommend you do when you jump into a real eye as a surgeon is the back end of the case, where you're just removing the viscoelastic, or you're just placing the lens, as opposed to the front of the case, which gets at this whole thing that Lori's talking about, and that is that everything builds on everything. And so if the very first thing you do is something like the wound, and you really make a bad wound, everything else goes sour. So try to get your early experiences at the end of the case.
Absolutely, 100%. And that's exactly what tip 2 is meant to say, is that, and I don't think you fully realize this until you screw up one of the earlier steps, and then you realize how much it can make what's supposed to be an easy case really challenging. And that's so frustrating, because you're just going to beat yourself up because you have this perfect patient that should have a routine cataract surgery that you can really work through, and then you say you make your wound wrong, then for the rest of the case you're dealing with the downstream ramifications of that. So just keeping in mind that everything, even from what I'm going to talk about with positioning and exposure all the way to the very end, builds upon itself. And
yeah,
Ivo, I think you had a great explanation for that.
Yeah, we have the A, B, C, D, right? If A goes wrong, then B is bad, C is catastrophe, and D is disaster. So I agree completely with you that you build the surgery, right? So it's very important for you to understand all the steps and the order of them.
All right, so here we are. We're just gonna, you'll see this pyramid over and over again throughout the presentation. So we're just gonna walk you through the case. You can go to the next slide. So tip number 3, set yourself up for success. And can't emphasize this enough. Again, it goes down to making the case as easy as you can for yourself, but positioning is very important and exposure is very important. Ivo, you can go to the next slide. This is
just before I go to
sure.
the next slide, we have a question from the audience.
Okay.
When we are teaching, they're asking if you guys do specular microscopy in every single case before a case with a resident.
No.
Okay.
No, I don't.
Great.
Okay, so this is an example when a patient's under a drape, how it can be really challenging to tell what exactly is wrong. This patient, you can see when you look at the eye, they look like they're prepped really well, they're draped really well, but the access to the superior limbus is limited. And this is something as simple as the patient is positioned with their chin down a little bit. So when they're focusing on the microscope, you're not getting great exposure. And if you go to the next slide, you can see that a simple correction of having the patient lift their chin, and sometimes you have to remind them of this if their head's not taped. You have to remind them over and over during the case. But if they lift their chin a little bit, suddenly now the iris is parallel to the floor and you have a much better view. Along the same lines, if you have a patient with a deep orbit and you're getting a lot of pooling of fluid, you can use a little sponge drape. This sponge drain, this is just cut off of the edge of a instrument wipe, and you tuck it down in their fornix, and it can help wet fluid away throughout the case for you. And then also retrobulbar anesthesia can be really useful, not just for akinesia and some of the other benefits like mydriasis and decreased photosensitivity, but if you get it in the cone, you'll get some nice proptosis, and that can be helpful for patients with a really deep set eye. And I've actually used this for that reason alone. Somebody who otherwise you could do topical on, using a block can be really helpful.
I love it. I have just one saying about this. I always say to residents that there is nothing worse than an uncomfortable surgeon and an uncomfortable patient. Both of them, right? It needs to be the perfect position. The patient needs to be comfortable, the correct anesthesia, and also to take care of the ergonomics of the surgeon. I think there are things very important there.
I was just going to mention, I just think it's so important, the concept of having a good start to the case, and for that reason, you're not going to believe it, but basically, I almost never let residents drape the patient, because it's so important that when very early residents drape the patient, the whole thing can go sour just because the draping's not good. And so it's a weird thing, but it's one of the last things I turn over. You'd think it'd be the first thing because it allows me to have more snacks and come in the OR later, right? But the truth of the matter is, it's one of the things I'm really nervous about giving up because of what Lori's talking about, and that is that it builds and it builds and it builds. And so I really want you all to pay attention to good draping. And everybody does a little bit differently, but figure out how you're attending, if you're in a resident setting, does the draping, figure out why, what are the intricacies of that drape, and really know that well. It's a very important part of the case as you move forward to set yourself up, as Lori said, for success.
Yeah,
go
there's
ahead.
asking about what do you guys use for the retrobulbar blocking?
We use a mix of bupivacaine, lidocaine, and Ydase, and we use about 4 cc's in the retrobulbar space, and then 1 cc that we place in the area of orbicularis in 1 injection.
Great. Lori, sorry.
Yeah, I wanted to say 2 other things that I don't have here. One is to not be afraid to ask anesthesia for help. I think we take a lot of pride in being able to do a topical case and not ask for anything, but a lot of times anesthesia has nice tricks in their pocket for a coughing patient or a restless patient. So don't forget they're there. And then the other thing is don't worry about taking extra time to make sure everything's perfect before you start. I think we feel a lot of pressure from the OR to keep moving and to get going, but you'll never regret taking that extra few minutes to position the patient properly, because like you said, Ivo, once they start getting uncomfortable, then your stress level goes up immediately. Okay, we're gonna move on to wound construction. If you wanna go to the next slide. So tip number 4 is be very particular about your paracentesis. And this goes back to paying attention to every single step. As most of you know, it's a small 1 millimeter uniplanar radial wound. It's where you're gonna go in and out with medications, you're gonna hydrodissect, you're gonna put viscoelastic through this incision, and it's also gonna be where your second instrument's used. Next slide.
I just want to say something really quick. Guys, remember the paracentesis and stay to the end of the talk, because the paracentesis is going to be something very, very useful. And it's somebody who doesn't like to do a paracentesis in a routine case is telling you that. So wait for the end. Okay.
And location really matters. So it's generally going to be about 60 to 90 degrees away from your main wound, depending on what your second instrument is. What I like to do, because you're going to put your paracentesis in first. So what I like to do is rest my hand where I'm going to have my main wound and kind of envision where exactly my main wound is going to go, because this isn't always in the same spot. So a patient with a different type of orbit or a brow you're working around, or somebody you might want to be neutralizing a little astigmatism in, you might adjust where your main wound's going to go. So envision where your main wound will be and then put your paracentesis in relation to that spot. There's lots of ways to get this wrong. You can make your incision too close, too far, or too long. Any of these problems can cause you to have difficulty with spinning a lens, as you'll see here in this video. This is me. My paracentesis is too close to my main wound, and I'm having a hard time rotating the lens. So if you have a long wound, you're going to have trouble with oar locking or getting in and out of it well. And the solution is really quite simple. It's just to swallow your pride and to make another wound. I don't know, Dr. Oetting or Ivo, do you have any tips on paracentesis before we move on to main wounds?
Well, I just wanted to talk, we're going to talk later about from the teacher's point of view, but from the surgeon's point of view, what I would recommend you do until you have about 50 cases under your belt is I would put a little dot with a marker where your incision is going to be. I want you to think about that first. And sometimes the incision is a little more inferior, sometimes more superior. It depends on how big the cheek is, depends on your exposure, depends on if it's a right hand or left hand. It may depend on astigmatism, but I wouldn't encourage you to worry too much about that in your first 50 cases. Try to think about where the incision is, and then relative to your incision, make your paracentesis. So put a dot where your incision is going to be, and then think about where the paracentesis is going to go. And it depends on what second instrument you're going to use to some extent. And so if you're going to use a chopper like Lori's showing here, then it's about 60 degrees over. There's other instruments where you might want to make it 90 degrees over. But I want you to think about the incision first. And the reason it's so important is sometimes people will make a paracentesis in the wrong place, and then they'll make their main incision relative to the paracentesis, and the whole case is messed up because of that, because the incision was made in the wrong place. So first things first is the incision, then the paracentesis. One of the things that can happen if the paracentesis, as in this case, is too close to your main incision, is you will push the eye over to the nose if you're sitting temporal. And that's because, just think about the vector forces. You've got these two things very close to each other, and especially if you're just getting started, and you'll end up pushing the eye over to the nose. So if you begin to notice that that's happening, you want to ask yourself a couple questions. One question is my main instrument hand too high? And the second thing is ask yourself if the paracentesis is too close. Hopefully the paracentesis is too close, because that's an easy fix. You just make another paracentesis, as Lori mentioned. And actually, Lori and I did a case when she was a resident where we had 9 paracenteses, 9 of them, plus the main incision. So you can make a lot of paracenteses before that cornea falls off. So don't worry about making another one, okay? Anyway, there's so much we could talk about with the paracentesis, and we'll talk later more, but I really agree with you, Lori, about how important it is.
Okay, and then I'm going to hand over. Dr. Oetting, I was going to hand over to you here. Dr. Oetting, you're on mute.
Thank you. The main incision is very important, which is so obvious, I suppose, because there's so much work regarding the main incision. There's so much going through it, but I think the important thing with the main incision is, number one, get it in the right spot, which we just talked about, and I think number two, you don't want to make it too long. You don't want to make it too short. When you're just getting started, though, it's probably better to make it too short than too long. When the incision is too long, there's a lot of things that can go wrong, and we're gonna show you a video of that in just a second. When it's too short, the main problem with being too short is you can get prolapse of the iris, which is a significant issue, but it's not as bad as the issue we're going to show you in a few minutes. Now the width of the incision. Oh, here we go. This is very good. The incision also could be too anterior or too posterior. And so when the incision is too posterior and it includes the conjunctiva, then you can sometimes get fluid which will come from the inside of the eye and get trapped under the conjunctiva. And we tend to call that a conjunctival donut, because it looks like a donut where the center is open and then there's this large amount of fluid under the conjunctiva. And this problem is really tricky because you'll get fluid that'll collect sort of in that volcano or in that donut, which creates this negative weird lens, and everything looks super small. And so as soon as you detect that this donut is starting to happen, you want to stop and do a little peritomy in that area so that the fluid cannot get under the conjunctiva easily. So that's one of the main things I'm looking for in the very beginning of the case as the attending, is I'm looking to see if there's a conjunctival donut starting, and if there is, I'm going to fix it. If I'm doing the case myself, I'm doing the same thing. So here's an example of that. And so you can see that the incision on the right side is a little bit too posterior. And so fluid is getting underneath the conjunctiva. And now the assistant's working like full time, removing the fluid so that you don't get that weird negative lens. You can see how things look a little smaller when you have fluid all across the anterior cornea there. And so the solution to this problem is prevention early on. As soon as you see this happening, you want to attend to it. And here's another example of the wound being too long. This is a great example. This is a case from a few years ago. And you can see already in the intro slide that it's too long, but watch what's going on here. The keratome maybe starts a little bit too anterior, but the tunnel for this just goes way, way too long. And it may be that the eye was a little soft. There's a tendency when the eye is soft for the incision to be longer, but that's really a long wound there. And so now we're making our grooving, everything's going pretty well, but at the end of the case, look how much fluid has been forced into the cornea, which makes it very difficult to remove the subincisional material. It makes it harder to make sure that you can safely get that out. So making the wound too long can be a big issue. What I would recommend is if you make the wound too long, the very first thing you should do is make a funnel a little bit to the right, a little bit to the left, so that the inside of the incision is not quite so small and so tight. All right, and we'll do the next slide. Any other comments about that from y'all, about those two issues?
No, I think you're right. Just to make sure that your pressure is appropriate when you start your wound, because if you have a low pressure, your wound's going to tend to be long. And the opposite's true as well. If you really tank the eye up with OVD, your wound can be really short.
Okay, very good. We'll go to the next slide. Here's a wound that's too short, and this is more common when the eye has a lot of pressure. When you're making your incision, there's a tendency for it to be too short. And you can see that some hydration here makes it a little bit less likely to prolapse out. But let's stop right there just for a second, and let's ask ourselves. This is a really interesting question, right? So we've got iris prolapse. And I think there's sort of a giant squid axon reaction that everybody should have when you see iris prolapse. And I want you to stop and ask yourself, what's the next thing you're going to do? The very next thing you're going to do. And I think the next thing you're going to do in this situation is you have to go right to that paracentesis and release fluid from the inside of the eye. Do not go for the iris yet. It's very tempting, but do not go for the iris, and go right over the paracentesis and release fluid. So don't do that. Oh, I think it's, don't try to push it back in right there. Go right over the paracentesis first. And that releases fluid pressure from the inside of the eye and makes it more likely to do it. And let's go to the next slide. I think we've already seen that. Here's a really common issue, and that is that the keratome will be tilted. And so you can see this is a right-handed surgeon. And so the right side of the keratome is more posterior and the left side of the keratome is more anterior. So you can see the incision going in is tilted. The left side of the incision is going to be shorter than the right side. And this is very common as you're getting started. Matter of fact, it's almost 100% of people in my experience, this happens when it started. And if you're right-handed, it's always tilted that way. And so oftentimes the wound will leak, and oftentimes the right side of the incision will be posterior to the conjunctiva, and you'll get a donut. Ivo, you had a good tip yesterday about this situation.
Well, I think this is very interesting because the problem here is to communicate with the student, right? Sometimes you say, okay, you're tilted, you're not tilted, and they don't understand the three-dimensional concept about this. So one of the good things I do for everybody who's there teaching is I talk about the light reflex in the blade, and it should be uniform. If that reflex is not uniform, then mentally you can understand that it's tilted. So the student just keeps trying to make their reflex completely homogeneous.
I think that's a great tip. I've never really thought about that before. What I usually will tell our residents when they're starting is there's like 100% chance they're going to tilt it, and try to challenge them not to. But it's just so incredibly common. If you're right-handed, you tilt it one way. If you're left-handed, you tilt it the other way. But just being aware of it's really important. We're really interested in simulation, so we wanted to talk a little bit about that. Before the formal session started, we talked about just how much we're using these simulated eyes now. There's a bunch of them I have right here. We've been playing with them so much. And I really think the simulated eyes are a great way to learn, and in particular to learn in this COVID time. The nice thing about the simulated eyes is they allow you to do stuff in your operating room. And so if you have the artificial eyes, you can bring them to your operating room because there's no cadaver products or animal products. And so you don't have to have a wet lab. You can just use your operating room. You can use your stuff from your operating room. And so for that reason, I really like it. I think there's several eyes that are pretty good. Some of them, unfortunately, are partially down right now because of the COVID time. But the Bionico eyes, they're still selling eyes, so that's one place you can get them. We really like these eyes from Simulated Ocular Surgery, which are the Philips eyes, which is what was shown here. But anyway, they're very good for practicing the incision. It's hard to do that on something like an IC, and so but for incisions, the simulated eyes are really good. Any other comments on that from y'all?
I think main wounds are like free throws. Ideally you would be able to do the exact same thing every time. But it can be challenging. And I think the other thing to keep in mind is to realize that you're making your incision on the way in and on the way out. So if you break your focus as you're removing the instrument, you risk causing an issue with the wound on the way out as well.
Yes, that's a great point. Just an interesting idea. Our chief of cataract surgery here at the University of Iowa is a fellow named Tim Johnson, who's one of my heroes. I know he's one of Lori's heroes too. And he really won't let you do the incision on his cases. He'll let you do everything else, but he won't let you do the incision until you're really senior. And I always thought that was interesting because that shows you how precious that incision is and how hard it is to learn when he'll let you do the rhexis or let you do nuclear fractus, but he won't let you do the incision at first. I mean, obviously he eventually teaches you how to do it really well, but I think it's a much more important part of the procedure than most of us let on. Well, we're going to go on to the next phase of the surgery, which is the capsular rhexis. And for junior surgeons, those with less than 100 cases, this is often the stumbling ground. This is the part that people dream about before the day of surgery, and that's because it's so important. It just sets yourself up for goodness or badness in the rest of the case. And the goal, of course, is and we've just got a great comment from Dr. Marino, and that's also the first thing other surgeons notice when they look at your patient. It's sort of the signature, as Dr. Devgan talks about in his wonderful series of cataract coaching. He talks about the signature of your surgery is the rhexis and your incision. So the important thing is to have it centered, to have it round. You want it to be less than the size of your lens, which is somewhat less than 6 millimeters. But most importantly, you want it continuous. That's the most important thing. And you have to maintain the chamber when you're doing this. And that's probably the biggest problem people have when they're getting started is they don't maintain the chamber. They push too much down on the wound and they lose viscoelastic. And so one of the important things to remember is to maintain the chamber, add more viscoelastic, use dispersive viscoelastic at the wound to try to keep that chamber formed when you're doing this. And so when we're doing surgery with early residents, we will use a lot of viscoelastic, and so we'll usually open 2 or 3 viscoelastics. So let's roll the video here, and we'll just show this video. And we're going to show 2 things here. We've got something interesting coming up, but right now we're just going to show a standard rexus. You can see how we're getting it started with a needle, and then we're going to use forceps. And there's really 2 movements, I think, with the forceps. One, which is what we're showing here, where you sort of lead the skier and you sort of pull it. And that's when things are going well, that's a really effective strategy. It doesn't work as well if it's beginning to go out or if you have a very elastic capsule. But this sort of leading the skier technique is very common and useful. And we're going to show in just a few minutes sort of more of a strategy where you pull to the center or do shearing. And what you want to do is you want to sort of think about the path you want the rexus to take. And really the forceps take that same path. And this is a video from Lori that she's sharing with us, but this is a great example of that, sort of just following the path as you lead that skier around that round circle of about 5 millimeters. But the really tricky thing about doing this, honestly, is maintaining that chamber. And most people get into trouble when they've lost their viscoelastic. So as a teacher, I am constantly pumping viscoelastic into the eye to keep it formed for those early cases. So if you're an early surgeon and you haven't really gotten it squared away at the wound, you haven't really figured out yet how not to push down, this part of the procedure is difficult mainly because of loss of viscoelastic. So I think we've got something really cool we're going to show now. I think Ibo's going to do a live. It's a live surgery, but it's not a live surgery on a patient. It's a live surgery on ICI, which is a technology probably most of you are aware of, where we use a simulator. I think he's getting it set up now.
Can you see me there?
I'm not seeing you. I don't know if.
No. Please tell the audience I'm here in a virtual.
Okay, now I can see it. Yeah, I can see it.
You can see me?
Yep.
Okay, so right now we're doing virtual simulation. You were talking about artificial eyes. They're amazing. They help us, to use the real machines and many other different techniques like incision. But when it comes to somebody so powerful as their capsular rexus and so difficult, we have virtual simulation that can help us a lot. And right now, in this time of COVID and with low volume, I advise you guys to use this kind of tools to keep and improve your skills. Right now, Dr. Oeting was talking about doing a capsular rexus with guidance. As you can see here, it's a little far away, but I can change everything. I can change all the setup. I can put guiding elements in the cornea and the anterior capsule. And imagine what is this to teach, especially because one of my the things I most obsess about, that is the hand position. So right now, you're going to probably see me do a capsular rexus with a guided element, but you're also going to understand my hand position and how the behavior with the eye it's in a dynamic environment. And best of all, you're going to see this machine giving me objective feedback. So imagine how important is that for your learning curve. I hope you can see here. If not, we can do stuff in the future. Okay, but I'm going to put viscoelastic. I'm going to do an initial tear position here. Okay, I can put weak sonulus. Maybe let's not do that in live surgery. Okay, let's have a normal eye. Okay, you can put start here. And we'll grab the forceps. You can see there the eye will guide it down. I'm going to zoom so you can see it. And then you can see me do some light virtual surgery, okay? So you're going to see me there. Okay, just do it and watch my hand position. I think that's really important, right? When we're teaching, it's not only about what's happening inside the eye. This is, for example, the most difficult part, pivoting, some incisional part. And you can see perfectly what I did with my hand position to make it.
Ivo, si podés acomodar un poquito más la cámara que no se alcanzó a ver bien la mano. Hacerlo nuevamente con enfocando un poquito la mano.
Later, but for time, I just wanted to know, and here I'm gonna do some zoom up about what the machine is telling me. I think this is the most important thing, right? He's evaluating how the roundness, the centering, the deviation from the radius, how efficient it was, and if I heard it, different different elements like endothelium, iris. So I'm going to share my screen again, and for matters of time, we're going to keep the talk, but I will strongly recommend to keep doing stuff like virtual surgery. Tom, all yours.
Very good, thank you. So let's go to the next slide. This is a technique that I really recommend everyone know. This is Lori's slide, so I know she agrees. And that is the use of the little capsulorhexis tear out rescue. And basically, it's named after this fellow Brian Little, who's a retired surgeon now at Moorfields, but he was a wonderful teacher. And basically, the idea is when you're starting to go out, or you're starting to go radial, you sort of stop for a second, add more viscoelastic in a safe way. And then what you want to do is you want to, instead of going in the same direction you were going, you want to go in the opposite direction, put some tension on the tear, and then you pull to the center. So you sort of shear to the center. And so let's have the next slide if we could.
I think our slide master is in transit.
Oh, he's coming. Okay, very good. That's good. That's all right.
One thing, we did get a question about how many times you regrab when you're doing capsulorhexis. And I think the answer to that is as many times as you need to. So when you feel like you're losing control of the tear, I think it's good to stop and regrab, but it depends on the surgeon. Some 2, 3, 4 times. And I feel like early on, it's better to regrab more often than not.
Yeah, I agree with that. I think, a really good surgeon might do it 3 times or something like that. And then an early surgeon might regrab many times. But each of those regrabs with early surgeons is an opportunity to lose viscoelastic. It's an opportunity to, lose your chamber a little bit. And so you'd like to be as efficient as possible with that. These are 2 simulation platforms here. The IC, which we just saw Eva working on, and then on the right is the Cataro eyes, which is pretty good for Rexus. Probably the best platform for the Rexus or the Phillips eyes from the simulation eye point of view. Let's do the next slide. All right, so we're gonna switch gears to Hydrodissection. And
okay, Ivo, can you go to the next slide for us? We lost him again.
We lost our fearless leader. Oh, there he is. He's so
There
busy.
he is.
He's probably working on another webinar somewhere else.
Yeah, exactly. So tip 7 for hydrodissection is overall, the main thing you want to achieve here is to make sure your lens spins freely. There are lots of ways to do this right and to do it wrong, but I think this is an underappreciated step. I think it's one of the harder steps of cataract surgery because you can really do things wrong. But it's super important to make sure you're just under the anterior capsule with your hydrodissection cannula. That way you get a true hydrodissection and a true cortical cleavage. You also want to make sure you're peripheral enough so that the BSS goes out around the equator and not just back into the anterior chamber and washes out all your viscoelastic right off the bat. while hydrodissection, you kind of have to have your eye in multiple places, but you want to watch for the lens vault that you're going to see as fluid moves behind the lens, and make sure you're blotting that down frequently so the lens doesn't either pop up into the anterior chamber or cause iris prolapse. Along those same lines, hopefully you're not taking on these cases too early on, but eventually you want to be very careful in cases where you're concerned about a posterior capsular issue in small eyes, because everything starts out more crowded. It takes less volume to get into trouble. And then also in IFIS cases, the iris is going to want to come out of the wound as well. So just remember fluidics. When you're injecting VSS, things are going to move out of the area of least resistance, and that's your main wound. So iris is going to come out, your viscoelastic is going to come out. And then one of my favorite tips is, if it's not spinning in your two traditional areas that people try sort of at 1 o'clock and 11 o'clock, you can go in through your paracentesis and do a little subincisional hydrodissection, and that typically frees the lens. So if you go to the next slide, I have a video illustrating that. So here I'm hydrodissecting in my go-to spots. You see a nice fluid wave. So you're thinking that we're getting a good hydrodissection. Blotting down gently. And then I kind of dig into the lens, and I'm doing a little bit of hydrodelineation and trying to spin the lens at the same time here, but it's not really spinning, and I don't want to start stressing the zonules any more than I already was. And so I go subincisionally here and try and hydrodissect a little bit there, and then the lens spins freely. So really take your time on this step and make sure the lens is mobile before you move on to nuclear disassembly. Any extra tips on that, Dr. Oding or Ivo?
I just want to comment a couple of things. Number one, I think one of the interesting things you were doing as you were doing that example was you were pushing down on the lens a little bit, and you're releasing fluid from behind the lens. This is probably the most common time during the surgery where you'll have iris prolapse, because you'll put a lot of fluid that ends up behind the lens, and you'll simultaneously be sort of pushing down the wound a little bit. And so you'll have a lot more fluid pressure behind the lens than you do in front. And so everything comes up and the iris prolapses out of the wound. And so when that happens during this phase, once again, I want you to stop everything and go right to the paracentesis. And I want you to remove fluid from the anterior chamber. And I want you to go right to the lens and just rock the lens a little bit and get the fluid that's trapped behind the lens out. So if you get the very common sort of early surgeon thing where you get prolapse during hydrodissection, don't go to the wound, go to the paracentesis, rock the lens a little bit to get the fluid that's trapped behind the lens out. And then oftentimes the iris will nicely go back in, or at least then you can be more safely and attending to the iris. And the second point I want to make is it takes more pressure than you think. So when you're operating with your senior surgeon, ask them to show you how hard they push on the cannula, on the syringe, because it's surprisingly forceful. So one way that Dr. Johnson shows us is he'll squirt off on the side and show you how much force it is coming out. But what I'll find when people start is, they'll be fussing around for 5 minutes on hydrodissection, and you look down at their syringe and they've used like 0.1 cc. And so it's a much more vigorous dissection than you would expect. And so just pay attention to the amount of force that's being used and try to mimic that as you're learning.
I just wanted to add that one of the most important things about this step is we don't give this step the importance that it has. It has high risk, right? If you have a problem in hydrodissection, you can have a drop nucleus and things can go really bad. And since I'm with the simulator, I don't want to do any hydrodissection for matters of time. But I want you guys to understand that the simulator give you 8 different, actually 10 different levels of hydrodissection for you to respect and to be prepared for every single case, right? I put you an example. The machine will tell you how attached is the nucleus, the consistency of the cataract, if the capsule is stable, and the visibility, very important, right? You can go to level number 7 when, you have an increased attachment, The capsule condition maybe not that good. So what I mean by this is we have tools now to be prepared, as Lori said in the beginning, right? Be prepared before the surgery, watch the case very good, and then train yourself with no risk with all different situations. Then we have, well, we have actually, this is very important. We have a lot of questions from the audience. We're going to go to them in the end. And then we have another poll question. So maybe Lisandro can tell you, can show you the question to you guys, and you can tell us what you think. It's basically what type of lens is more challenging to you. This is going to be very important for the discussion. Okay, let's see what the audience thinks. So 37% dense, laterally brunescent, but there's different opinions. I think this is very interesting. Could be a very interesting discussion. Lori, Tom?
Sure. If you want to go to the next slide, I'll touch on it and then ask you guys for your input. So in general, it probably matters what you're exposed to, right? So the lenses you're exposed to the most are probably what you're going to be most comfortable with. And also your background, whether you're familiar with extra cap or not. But I think it's good to sort of recognize patterns and have a strategy for different types of lenses. And so if you have an idea, again, looking at the preoperative notes, looking at the vision, looking at the exam, reminding yourself of all of that going in, if you have an idea what the lens is going to be like, you can have a strategy going into the case. So oftentimes, soft lenses can be actually very challenging to remove safely. And so, because you can't use your traditional divide and conquer or chop, sometimes that can be just mushy and more difficult. So sometimes lenses can just be straight aspirated with the IA. Sometimes you're going to want to bowl out the nucleus and then you can collapse the epinuclear material. And then oftentimes these lenses will prolapse pretty easily into the anterior chamber where they can be aspirated, but you have to expect that and be ready to deal with that. And then a sort of variation of chop, just a soft chop where you're not really using much energy, is another option. And then your moderate lenses, I think, are best for beginners. So just a 2+ nuclear sclerosis is really nice. That way you know what to expect and can get used to divide and conquer. And then if you could go back to the last slide real quick for me. And then for your dense lenses, again, these present a whole different variation of challenge, but being liberal with dispersive OVD, I will often put in more dispersive right before I start nuclear disassembly, and just to recoat the endothelium, because you've done hydrodissection, you've been doing a lot in the eye, your capsular rhexis, you might have lost some OVD, so just replenishing that. And then you can always go back on divide and conquer, just knowing that you're going to require a little more energy. Different variations of chop might be a little more gentle in the zonules, but you have to be comfortable with phaco chop. And then something I think is really useful if you have access to it, I was able to use it as a resident, is MyLoop. MyLoop is awesome, and I'm going to show you a video here. MyLoop is awesome for these dense, leathery, brunescent cataracts that have a really dense plate that can be hard to get your quadrants through. And so MyLoop is just this nitinol loop that you deploy out around the nucleus, and you spin it until where you're about halfway under the nucleus, and retract the loop. You can see this gold flash here. That's the nitinol loop going behind the lens. And you rotate your hand to where you're halfway through, and then you retract the loop, and it cuts these really nice quadrants. And you can do it. You can make 6 pieces, you can make 4 pieces, but sometimes getting these first 4 pieces is the hardest part with these really dense lenses. And so MyLoop is a nice, safe way to do this and reduce your phaco energy. Beyond that, sometimes these just require extra cap or a really, really deep groove. So you can see that nice division we have here. And then we're going to retract the loop again after we've redeployed it, and you get your 4 quadrants. The second instrument's there just so the lens doesn't tilt up out of the bag. And you have these really nice sharp, be careful, but sharp pie pieces that you can pull forward and emulsify. So I don't know if you, Dr. Oding or Ivo, have any additional tips there. It's a big slide with lots of content.
I think it's great to think about from the density of the lens as your starting point for what your strategy is. And I also think it's an important point you made where you talk about the ones in the middle are the ones for starters, which is surprising because you would think that the soft ones would be the best ones for starters. But really the outside of your comfort zone is where things are tricky. So the very soft ones and the very hard ones are the ones that are tricky. So I like that sort of first sort of line of thinking when you're doing nuclear fractus, which by the way was mentioned as the #1 thing people are worried about that are here on this call with us. And then the my loop I think is very useful, particularly in somebody like myself that's not really comfortable doing small incision extra cap. And I'm not comfortable because I haven't done a lot of them. I think so in that particular situation, it allows you to push the limits of what you can do with phaco, because it'll break a really dense lens which has a leathery back into 4 nice pieces. We got a question from Antonio while you were talking. He was wondering, he doesn't have access to that device. What should he do? And I think for Antonio and others that don't have that device, just have some technique like small incision extra cap for the really dense ones, so that you don't get past your comfort zone with whatever that technique is. And until my loop came out, what I would do for the really tricky dense ones is I would do an extra cap, because that's what I was comfortable with. But what the MyLoop has done is it's extended my range of a smaller incision. Now for Antonio and those, my understanding is the MyLoop, some people off-label are using it more than once. I'm not sure if that's true. You could find out about it, or that there may be some device like it that's similar, that's reusable. But it is cumbersome because it's supposed to be single use. But anyway, the important point I think you're making, which is that the first thing you think about is how hard's the lens, and then you change your strategy depending on that.
And I think those concepts really relate to tip number 9. And this is one of my favorites. I thank Lori to give me this, because it's everything about the plan, about the action plan, and about complexity. Even a simple case can be complex. And we wanted to show you so many different, a slide with so many different things that can happen. Because a surgeon is that. A surgeon is it's a person who needs to make so many decisions depending on what's happening. I put you an example. You can have a technique, your preferred technique, but it depends. Even in the same surgery, you need to switch techniques, right? That's what an expert is. That's what mastery is, to adapt to every single situation. And when we talk about this, I always like to talk about the motor skills we talked about, right? How you need to do fine motor skills. But when you need to make decisions, when you need to have all these cognitive skills about problem solving, decision making, anticipation, we have been talking about this. And this is something that at least we should think about every time we face, even from a normal case to a complex case. And I'm really passionate about the mindset skills. I think also we need to be like elite athletes or elite violinists. We need to be in the correct mindset every time we're doing surgery. We can improve our outcomes by being in this peak performance state that we can achieve, and we can train to be in that place. I would love to know what Lori and Tom think about this. I want to go really fast because I think the best part is the end part of what Tom has, waiting for us. But I would like a a comment for how do you guys train about this? Lori, Tom?
Go ahead, Lori. If you want
Yeah,
to.
I think we've talked about this throughout the presentation.
Exactly.
Is really and figuring out how to integrate all three of these is where you really become proficient. So again, just the mindset skills to me says preparation before the OR, and then cognitive skills is again trying to understand why we're doing what we're doing in the operating room. And then motor skills is just repetition, whether it's in the wet lab or with a simulator or multiple cases in one day. I think all of those things together is how you really become great.
Great, Tom.
Yeah, I agree. You know, the funny thing about it is as I'm getting older, there's a lot of residents like Lori that come that have much better hands than I do. But the point is I can still be better than her for a while because a lot of this is cognitive and sort of knowing what's coming up and anticipating and so don't underestimate how useful it is to do things like think it through, like visualize what you're going to do. I'm going to do this in a complicated case. I'm going to set myself up to excel in this way because a lot of it really comes from that. And there's after about 200, 300 cases, there's less really about how good your hands are, and it's much more about sort of planning ahead, thinking it through, anticipating the next move, so anyway, which is good news because hopefully you guys are going to practice for a long time, and you don't have to have super sharp, perfect neurologic systems like Lori and Ibo do.
No, exactly, and this take us to tip number 10. And it's awareness. Awareness is like the ultimate state of a cognitive state, right? My belief, as I showed before, is we should have an algorithm for every single case, for example, and can adapt, right? This is where machine learning or artificial intelligence are going to beat us because they're going to have a specific algorithm for every single situation with probabilities. If I do this, then this happens, So I believe that if we have a perfect state of awareness, for example, in this example, when your bag is at safe or is at risk, and you should pay different attention when you have all the alarms going on that, okay, I'm having surge, this is not stable, what's happening, how can I solve this? If we can have and I think we have. It's not that we could. I think we have ways now to train our residents in that awareness, to transfer those knowledge that maybe took us years to get. If we can transfer that to them, I think it would be perfect. I think we have an amazing, we had an amazing talk about tips, but now comes something like so powerful because in my humble opinion, and not because it's him there, I'm a huge fan of Dr. Oeting. He has done so much in education, and not only teaching, but research and a lot of teaching, in different places with Orbis in different parts of the world. But when I saw this, I saw somebody who was thinking out of the box, right? I saw somebody who was in the creative state, in the mastery state. So I would love for you guys to give us a couple of more minutes to understand this amazing concept of the power of the paracentesis. Dr. Wrighting.
Well, hey, thank you. So I want to talk about the paracentesis.
We lost the audio, Tom. We're not hearing you.
How about now?
Yeah.
Okay. So when you're in my situation where you're mainly are assisting in teaching.
Have a little sound. Let's try there.
How about now? Is that better?
A little better.
So I apologize for that. So what I was just mentioning is that the paracentesis is usually my main entry into the eye because I'm mainly staffing residents doing surgery. So I've discovered the amazing power of the paracentesis because of that. So I want to talk about 4 specific situations there's probably 20 or 30 ways I'll use the paracentesis, but I just want to specifically talk about a few of them. So let's have the next slide. So first off, the teacher always has to have a paracentesis. And now here's an example of a common problem with the paracentesis, and that is that we make the paracentesis and then the learner cannot find it. And oftentimes I can't find it either. And so just a little quick tip is this is such a common problem that the learner can't get in the paracentesis. It's so important to be able to get in because we want to add viscoelastic for the rest of the case. So here's what I do as a teacher. I'll just mark something like this Drysdale, and then we can see it. So in order to use the paracentesis, you have to be able to find it. And so that's a very basic point. But the paracentesis you've got to have, even if it's a dye and is paracentesis effective, you should make another one if we could. So here's an example where the learning surgeon is having trouble starting the capsular of the rhexis is too straight, and the resident surgeon cannot get the rhexis to fold over. And so you can see there's a lot going on here. You can see there's a lot of loss of viscoelastic, but the main thing that's kind of worrisome here is we're not able to get this rhexis to fold over. So as the surgeon here, this is a left eye, so I've got a paracentesis that's just for me because it's time for me to help. And one of the things I've learned as a teacher is just jump in quickly. So we added more viscoelastic. You can see it's more in focus now because I'm not accommodating, because I can't accommodate, unfortunately. And you can see I made a little incision, made a little flap and got it to fold over. And this is all through the paracentesis. I could have gone all the way around, to be honest with you, but that would have been sort of piggy and hoggy. So I got the resident started again. So the paracentesis and access to a paracentesis for a left eye is critical as a teacher. And the Roberto just mentioned it's also useful for subincisional cortex aspiration. And I agree with that completely, that sometimes the surgeon attending needs to go get the subincisional material through their paracentesis. So here's another example. Let's have the sound on for this one, if we could, Ivo. So this is an example of something I've learned over the years, and that is that you can almost do the whole case through the paracentesis if you just ask the resident surgeon to hold the phaco needle still and not do anything dramatic. Just hold it still, and every now and then step on the pedal. And you can rotate the material around. You can present the material to the phaco needle. You can protect the capsule. You can help keep the eye centered by using some force with the paracentesis. And so you can do so much through that paracentesis. You can almost do the whole surgery. It's really amazing if you think about it. And it reminds me of this old movie. Probably none of you have seen this movie, but I love this movie. And there should be sound here. Have you got the sound there going? Ivo, can you got the sound going? The sound's not working, but what he's saying is, I'm sailing, because he feels like he's really doing something exciting and sailing. And
I'm thinking.
And so similarly, when you're doing it, and even though you're doing most of the procedure through the paracentesis, or a lot of it, you still get the feeling like you're doing the surgery. And anyway, that's one of the times the paracentesis is most powerful. Let me show you one more example. Let me show you one. Let's switch to the next slide. Here's one more example. So in addition to using instruments through the paracentesis, you can also inject fluid, and you can change the fluidics. So here's some examples of doing that. Here's a resident surgeon that probably has maybe 50 cases under their belt, and they're having a little bit of trouble with the material going to the incision. They're doing some Swiss cheesing through the nucleus here. And so if you just add fluid through the paracentesis, you can change the fluidics. See how it changed the fluidics? I'm squirting fluid through the paracentesis there, and everything went right to the tip. And it's amazing how powerful that is. You just create little eddy currents in the eye. Here we're going to do it again, same thing. We're Swiss cheese through. It's not coming to the tip very well. And so as the teacher, I'm just going to say, okay, let's just move forward. I'm just going to squirt a little fluid in here just to get this going. And it just shows how you can change the fluidics through the paracentesis. This is especially useful in early residents where they're not very good at that second hand yet. You know, eventually they'll pick it up and it won't be an issue. But the paracentesis is a very powerful tool for the teacher, and you always have to have one. And I appreciate the opportunity to talk about it, Ivo. I'm unfortunately, I could talk forever about the paracentesis, and people can only stand listening for about 5 minutes. And I think we've done enough, but thank you very much.
No, I think it's amazing, and I think everybody there teaching and everybody there learning could use this this amazing way of thinking, that to use the paracentesis, so the teacher, the coach, or the mentor, it's helping like real time and into the student. I think it's an amazing idea. What do you think, Lori? Did you have the chance of having Tom in your paracentesis?
Oh yeah, and the thing is when you're an early surgeon, you're so focused at the tip of your phaco instrument that you hardly even notice there's this magical extra hand coming in and saving you when you're losing OVD or your pieces are going everywhere. And so, oh yeah, and for the record, when we had 9 paracenteses, it wasn't because I kept putting it in the wrong spot. We had like hooks and capsule rings and everything. So yeah, it's really important. And I think having that extra person there in the beginning and letting you be so focused on what you really need to at the time is really important.
Actually, you've got this slide up here. If you go, there's a Facebook page we have called Cataract.Surgery, and you can look up Lori's, so it's called So Many Paracenteses, and you can look it up and you just won't believe what she's done there.
Yeah, it was such a great pleasure to have you guys. And I would love to people to understand all the resources you have for them, even in Spanish. People hablando en español, tienen catarata para cirujanos novatos in español, and everything in English. Amazing books. Cataract surgery is an amazing community in Facebook. I ask everybody who is with us, you know, to be in that community. I hope this is the first of many, right? The first of many, you know, virtual meetings that we can have. And I would love to just to give a couple of minutes to questions. There is so many, I couldn't, you know, go into the simulator and back. There is 25 questions here for matters of time. Let's try to answer a couple of them. I think it will be really nice for the people. Everybody here who loves phaco, I invite you on Monday to come to Master in Cataract Surgery. It's late in Mexico City but this is because we have people from Singapore and from Japan. It's going to be amazing. And I don't know, you guys saw any other questions you want to answer? I'm going to try to go and see if there is any that you can. Eleanor Cordero is asking if you usually make just one paracentesis or 2. So you have a bimanual irrigation aspiration. Tom.
We usually use axial irrigation with the IA. So we usually just make one paracentesis if it's a right eye, and if I'm with a resident, we'll make 2 for the left eye, so I'll have access to paracentesis.
Oh, very interesting. That's a good one. What about your second instrument of choice? This is a good one.
For early surgeons, we use that Drysdale, which is a very safe instrument. You can touch the capsule with it and polish with it. You don't have to worry about as much about injuring the capsule. So for early surgeons, we use the Drysdale. I wish you could have seen me when I happened to get on the elevator and Dr. Drysdale was in the elevator with his wife and the poor guy, and I just started squealing like I was a teenage girl that just saw the I don't know, Bieber or somebody. But anyway, the instrument that I use for more senior surgeons is the Cybele chopper, which is what Lori showed on one of her cases, which is a nice chopper for soft or hard lenses. So those are the two I use. Do you still use those, Lori, or have you changed?
I do. I still use a Cybele.
What about your preferred technique when you're teaching? I'm sure we talked about that depends of the lens, but what is the one you prefer in the beginning?
So we start everybody with divide and conquer, which is nice because you can do so much of that through the with one hand, and you can do so much of it through the paracentesis. So we'll typically have the resident make a groove, and then we'll use a nucleus cracker to divide it into two pieces. And then sometimes the two pieces will just pop up and we'll take them, or sometimes we'll actually divide it into four. And then as they get better, we'll do divide and conquer with two instruments. Usually I'm using the second instrument at first, and they're using the phaco. And then eventually they're using both instruments, but they don't typically use both hands until they've got at least 20 cases under their belt. And then after they're good at divide and conquer, which is typically 50 to 100 cases, then we'll switch to stop and chop, or a variant of chopping. Some of our residents will stick with stop and chop forever. Some of them will move to straight phaco chop, and that's our strategy. For soft lenses, we typically will either prolapse them up, or we use a soft chop technique with no vacuum, as Lori mentioned.
Well, for matters of time, we're going to finish for today because, Dr. Oiting and Lori just told us that they're going to be in the next one. We're going to be using more the simulator and keep, giving our colleagues amazing tips. I thank you so much for your time and for all the preparation that this has. I think people are very, very happy. And if they have any other questions, for example, somebody is asking me about, the cognitive and the mental training, I will be happy to answer that. I'm always online. You can contact me by any social media and I will reply right away. And thank you very much for your time. 1 hour and 15, like we said in the beginning. So I think this was perfect for our audience. Thank you, Lori. Thank you, Tom. Just a couple of words to say goodbye to our colleagues.
Thank you all so much for tuning in. I put my Twitter handle here because I post a lot of AAO journal related tweets, so snippets of information to keep you up to date on free articles and stuff like that the AAO journal provides, and then also some teaching videos and cataract and glaucoma related stuff. So I'd love to continue to interact with everybody online. But thank you, Ivo, for having me, and for Dr. Oiting for being an ongoing mentor for me as well. So it's been a great day.
Well, hey, thank you. I put my email and my Instagram and Facebook and Twitter, which is just cataract.surgery. I was able to get those like 20 years ago because I was on, believe it or not, I was on Facebook back in the days when you could barely put an image on there. But anyway, it really was fun. Ivo, I really appreciate all you're doing for education. It's amazing. I just want you to know, those of us that don't know a lot about soccer find you much more famous than that guy Carlos Bianchi, but whatever. It's just depends on your perspective. But I can't thank you enough.
You're touching a very, very complicated issue because I'm from Uruguay and these guys are from Argentina, and we are kind of rivals. But no, this guy won a lot, was an amazing leader, amazing coach, and I think we are going to learn a lot tomorrow from them. So
Awesome.
Thank you very much.
Thank you.
And let's see us in volume 2, okay?
Okay, very good.
Thank you so much.
Okay, bye-bye.
Bye.